Hi, my name is Michael Ivan. I'm one of the neurosurgeons here at the University of Miami, and I focus on brain tumors and skull-based surgery. This week, for the Connectome of the week, we'll be focusing on a patient of ours who has a lesion in the inferior parietal lobe on the left side. This is an 80-year-old gentleman who presents with having some transient aphasia that improved after steroids, and at the time of surgery, he had very minimal symptoms. We attempted to do a wake surgery on this patient, and this ended up being glioblastoma grade 4 with IDH wild type. For this case, the question is, beyond the speech and language mapping, what other networks do we really need to be careful of in this area? And so, the first thing is really try to understand what is this patient's symptoms, and can we explain them by understanding the patient's networks. So if we start by loading up our tracks and parcellations, we start first with the language system. There's no question here. We could see our tumor, which is here, is surrounded by the parietal component of the language network. So that makes sense that he's having these language issues. And it also tells us that anterior to the lesion is where we really need to focus our awake mapping. But interestingly, on the medial and inferior aspect of this lesion, we also have a significant component of the patient's visual cortex, visual network. And it's important to understand that to really understand what the risks of surgery are and explain them to the patient so they understand them. And also understand, if you continue beyond the contrast enhancement, what are the next set of deficits that you could expect as a surgeon to try to preemptively make sure the patient understands the risk and also try to avoid if necessary. In this case, if we remove the language system, we would just focus on where the visual network is. We can see there's this part that goes up just medial to the depth of our enhancement. On the left side, again, by a process of elimination, you could go through the different components of the visual system, which is quite complex. We covered this in one of the prior connectomic sessions. And we can see here that this most superior aspect is the dorsal stream. Now, the visual network is quite complex, as we talked about, and really helps with the brain understand, not only recognize what we're seeing, but also interpret it and understand its perception, both how it moves and flows through our vision. The dorsal stream of the visual network is really the how or where pathway. Those parcellations are involved in the processing of motion and spatial recognition or spatial understanding, as well as coordinating sensor-motor functions. Basically, the pathway is responsible for interaction of the world and how we're able to see it, especially as we're going through it. So as you're driving or as you're running, as you're playing catch, you're trying to catch a ball, and you need to understand, not only recognize that it's a ball coming at you, but the rate, the size, the shape, and where the location will be, so your body and your brain can take the most appropriate actions. Injury to this pathway can produce significant trouble to spatial perception and movement, and impair somebody's spatial guidance of motor activities, grasping, avoiding obstacles, or even walking down the hallway. Additionally, patients can experience visual overload when they have difficulty with shifting between objects in space, or deciding what is important and what is not important among all the objects that are kind of moving or in their visual kind of space that they're seeing. And it's difficulty for them to kind of continue or sustain this attention to an area of interest when there's so many other things that are interacting with them. So in this case particularly, we need to understand, as we move beyond the contrast enhancement, what are items, networks at risk, and be able to explain that to our patient to prepare them for what deficits could occur, and also understand that if we go through and that we find that there's more fluorescence or more flare 2 signal, when should we stop, when should we not stop? Because these are things that we can't really map very easily with awake mapping. We can protect the patient from speech deficits anterior to the lesion, but visual, it's much more difficult. Here you can see the preoperative and postoperative MRI with without contrast, showing the resection of the enhancement and a little bit of the flare. We did the patient awake with the speech mapping. Again, anterior to lesion without surprise, there was speech difficulties with stimulation, and therefore we really limited our resection anteriorly because of that. Again, deep to the lesion, we maintained the cortex and inferiorly because we knew, based on the preoperative, that there was going to be components of the visual network there. We wanted to preserve them for this patient's ability. Postoperatively, the patient did well. He had just a few days of mild aphasia and some difficulty with balance walking down the hallway, but that actually improved as the edema resolved within the first week postoperatively. That concludes this week's Connectome of the Week. I hope you appreciated it and looking forward to showing more cases here from the University of Miami.